Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guest is Dr. Jon Allison, a general psychiatrist who practices at Saratoga Hospital and is also an adjunct professor of psychiatry at Albany Medical College. Welcome to the show.
Thanks, Peggy. I'm glad to be here.
Let's start by just talking about your background. Where did you go to school?
I finished my medical training at Albany Medical College. And as soon as you finish 4 years there, I went ahead and went to residency there as well. Graduated from the residency program at Albany Med and then went to Saratoga Hospital. Prior to that, I have a graduate degree from Old Dominion University in counseling.
So you started out as a counselor and then you ended up getting your medical degree.
Right. Actually, I had worked as a counselor for probably 13 to 14 years. After that, decided to go back and add on the medical degree and now come out as a psychiatrist. So I have a background both in psychotherapy and now the medical aspects of psychiatry.
Now, do you want to talk about the difference between a psychiatrist and a psychologist? I think some people might be confused about the difference.
Sure, and I think, Peggy, that's a common kind of difficult differentiation. I think the lay press and often we sort of colloquially think of the two as the same. Use psychology to refer to psychiatry and psychiatry to psychology. And certainly both fields study similar things. A psychiatrist is a medical doctor who has been trained with a medical education first. A psychologist most likely refers to a PhD trained doctor, but is not licensed to practice medicine.
So psychologists can do therapy, and they have PhDs, and psychiatrists are the medical doctors.
Right.
That generally oversee the therapists, right?
Right. And in general, it can have some overlap, of course. Psychiatrists are trained to prescribe medications and to diagnose psychiatric illness. Psychiatrists are also trained to provide therapy, and some psychiatrists may choose to do that. Some psychiatrists may limit their practice to medication management.
Yeah, that's what I was going to ask you about, the difference, the different types of specialties that psychiatrists can have.
Right. Psychiatrists can do quite a bit, and in fact, on the personal side, I would say that's why I went back to medical school, was so that I could enhance my range of skills as a therapist. Starting as a therapist, there are a lot of things you can do with what we would call classic talk therapy, which really involves lots of different techniques, but in essence really sitting with a person and discussing what types of issues they might be having and how you could come to some sorts of resolution with those things. There are times, however, when you really need the other side, which is the biological piece, the piece that is the rest of the person, so to speak. The medical piece. There may be medical questions, there may be disturbances in what we'd call neurotransmitters or brain chemistry. And I think that piece is where a physician is particularly well qualified because they've been trained in that.
Well, today's show is about depression, and that's the focus of what we're going to be talking about. Do you want to talk about statistics for depression? How prevalent is it in the United States?
Sure. I'd preface that by saying depression is, of course, quite common in many aspects, and it's also moderately controversial because the word depression is thrown around easily, in a sense, and it's not always defined the same by different people. If you do a quick search on the internet, you may come back with a wide range of information in terms of how prevalent it is. And it may be that they were talking about apples and oranges, different kinds of things. The American Psychiatric Association, which would oversee my practice, would say that the prevalence of the broader category of what we call mood disturbances is around 9.5 to 10%, and I think that's as of 2005. Under that, and that's at any one given moment in time, that approximately 9.5% of the American population suffers from most likely a diagnosable mood disorder. And among the mood disorders, you have things like major depression, you have a lesser depression called dysthymia, and you may have the mood regulation difficulties like the bipolar disorders. Of that, the bulk primarily would be the major depression disorders.
Major depression.
Right.
Major depression is that the kind of thing where you cannot even leave your house and you really can't function very well?
Major depression would also have a range as well. And we have one set of criteria that we would use for diagnoses, but then we also have sub-criteria where we could say whether the major depression was severe, whether it was mild, whether it was moderate. So as a psychiatrist, it's not as clear-cut as, Peggy, are you depressed? Peggy, are you not depressed? For me, it would be a range of things, and within that would also determine what kind of treatment options we might pursue. But statistically speaking as well, some somewhat frightening things are that between the ages of 18 and 44 in the United States, major depression is the most debilitating illness. I think that should give pause to the impact it has on our society in a lot of different ways.
And what is the breakdown between the genders, male and female?
In general, most studies seem to show that females experience depression more than males. Now, that also is controversial because there are some questions about reporting methodology, the idea of women are often more forthcoming in terms of their identification of symptoms that might be regarded as depression. There is still a stigma in our culture that depression is seen somehow as a weakness.
What about signs and symptoms? How can we look at someone or look at ourselves and know that someone is depressed?
Well, I think when you look at signs and symptoms of depression, I like to think of a continuum as well. At one end would be someone who may experience some difficulties in life, and those are normal kinds of things. Things don't go well. One loses a job. Worst case, maybe a death of a spouse, death of a loved one. Those are all events that we can suffer sadness from. And one might say that in a sense is a bit of a depression. But depression itself, in a pure clinical sense, extends beyond just the feelings of sadness somebody might have.
I think that's how we generally look at depression, if somebody's sad.
And I think that's tough, and I think it does a disservice to someone who truly experiences depression in a clinical sense. Because the idea of sadness and that events haven't occurred as you would like, there are ways out of that. There are a sense that the expression one pulls oneself up by their own bootstraps, the idea that you can tough your way through something, that it just requires a strength of will to get yourself out of that situation. And when one encounters difficulties in life that result in sadness, that's often true. Depression, however, is different. Depression seems to last beyond that. Depression is what might remain after you've started your exercise program, after you've read all the books, after you've done everything that you could possibly do to try to make things better for yourself.
And what would be the signs?
So excuse me. The things that I would look for, there are a series of signs and symptoms. We'd want to look, first of all, at the physical kinds of signs, and those would be changes that you might observe in your appetite, for example. And that could go either way. You might decide that you've lost your appetite, and it's not and I say decide, it's not necessarily a conscious thing. You would find a loss of appetite. You may find an increase in appetite. But what I would look for as a psychiatrist would be, did that change in appetite result in a change in weight for you over a period of more than a couple of weeks? So a loss of weight or a gain of weight, both of those things could be possibilities. Other physical symptoms would be sleep. I think that's a very obvious one. And that also runs both ways. Some people sleep a lot. Some people have trouble sleeping. But the key there is that there is a disturbance in what might be considered normal sleep patterns. It could be difficulty falling asleep. It could be awakening in the middle of the night and having trouble going back to sleep. It could be what we call early morning awakening, where the alarm is set for 6, but at 5 o'clock you awake and you know you have an hour to sleep, but you just can't get back to sleep. So really you're looking at a range kind of sleep difficulty in some pattern. The last probably physical piece would be energy. And with that, there usually is a decline in energy in terms of perhaps some apathy about not wanting to do things you normally like to do. It's tough to get out of bed, tough to get going. It's just not the same as it used to be for you to be able to do things. Maybe cut into that as well. A little opposite would be sometimes people are anxious or irritable, and that might actually be the opposite of less energy. It might be feeling frustrated or feeling like it's difficult to tolerate things that used to be easily tolerated.
I'm wondering when one should be looking for signs. Like, for instance, how often is depression a secondary illness just related to something else? For instance, somebody's going through cancer treatment,
Sure.
somebody's diagnosed with Hodgkin's disease, with Parkinson's, somebody just lost a spouse or lost a pet, you know, and they're sad. But how often is it secondary to something?
Well, and that's where depression is complicated, and I think that's where psychiatry as a field is complicated, and perhaps at times gets a bit of a bad rap from the rest of my colleagues in medicine, is that we don't always have tests. We don't always have studies that we can do that show a certain bacteria that responds to a certain antibiotic. It's difficult because it's what we call multifactorial. There are a lot of different things involved, and there are circumstantial things that can contribute to real depression, and there are circumstantial things that may just result in sadness that someone may evolve through and grow and change as they need to. The difference, I believe, is that the pattern is that in depression people get stuck. People find that it really impacts negatively on their ability to function. And I think that's the point where I would use as a crossover to decide that, you know what, maybe it's time to talk to somebody. And that's where I think having a professional to help you make that decision is important. It's difficult. I tell patients that it's difficult to be both the actor and the audience at the same time. And that means that in your life, you are the actor. You are the main character. But it's very hard to often observe as the audience, objectively, what your life is like. But when you go and talk to a professional, oftentimes they're in a position where they're not in your life, where they can actually provide some feedback to you about maybe where you stand on things in terms of is there depression present or not.
Now, you're an adjunct professor at Albany Medical College.
Right.
Is your job generally to have the studying doctors recognize psychiatric disorders in their patients and act upon them? Do you think that physicians don't really recognize it as much as they should?
I think in the last decade there has been a tremendous increase in physicians' willingness to recognize the prevalence of mental disturbance in general, and probably depression is the biggest of that group.
Right.
And primary care physicians have come a long way in terms of their ability to recognize. And in fact, what's probably not surprising, but yet perhaps surprising, is that primary care physicians are the people who diagnose depression the most. By the time you get to see me, it's probably a little more serious or not necessarily as common as though having been seen by your primary care physician.
So they wouldn't necessarily just refer someone to you. They would just start them on medication and then
Oftentimes now we would see that a primary care physician may in fact be the primary care provider for depression. They may actually be the person who is treating depression. And many of these providers are quite skilled. And certainly the depression is common enough, and there are certainly a lot of medications out that it's relatively easy to manage from a medication standpoint. Where a psychiatrist might be needed is for the nuance, where there may be something a little more complicated about the depression, or whether there's a question of where the depression lies, and if there were a need to perhaps look at sort of the psychotherapy piece, because your primary care physician has the capacity to prescribe the medicine.
Right.
They're not trained to actually do therapy.
Now, you've talked about mood and how it's influenced, and there are a lot of things that influence it. Weather, diet, exercise, how your day's going, and all of that. But you've talked about serotonin, norepinephrine, and dopamine.
Right.
And those do you want to explain
Sure.
the fluctuation of all of those?
Absolutely.
And what they are?
I think maybe prior to that, I'd want to give kind of the idea, the precursor that depression, once again, is multifactorial. And the biochemical piece is certainly important. We do, of course, look at personality style. We look at environment. We touched on the environment in terms of the things that might happen to a person. Your personality style determines, in general, what is your sense of reacting to the world. When things happen, how do you react usually? And that's personality style. A lot of those things are learned and not necessarily open to change easily. But the biochemical piece is important. And I think perhaps a real take-home piece from this is that ultimately all of our experience is derived from and interpreted by chemistry at some point in our brains.
Right.
So as you and I speak today, and we're listening to each other, ultimately that's transferred into chemicals. So as science becomes more complex, we're able to understand better what those interactions are and to break down to some degree how our moods are affected by changes in chemicals. And you mentioned the three big ones, and that's the serotonin, and dopamine, and norepinephrine. And really serotonin and norepinephrine are probably the bigger of those two. Dopamine may be less involved in terms of mood. But it's not finished yet. It certainly has a long history in terms of trying to decipher how those neurochemicals interact. It is immensely complex. They interact with each other. It's not simply a matter of not enough of one or too much of another. It's a balancing point. And that there are balances at different points in the brain and different places in the brain that respond differently. So the whole thing begins to establish a very complex matrix that's very difficult to decipher, which is why at times I think psychiatry can be frustrating to a patient.
And it can't be measured.
Right now it's difficult, and right now I don't think we really are at a place where we have good tests that would say, give me a sample of something, Peggy, and I'll tell you this is what is going on, this is what you need. Ultimately, I think we're headed that way. Ultimately, I think we're going to be able to come up with some very good ideas about receptor sites and what types of receptors you might have and what types of responses to different types of neurotransmitters. Sort of map out, if you would, perhaps with some gene mapping, kind of, who is Peggy Mello and how does she respond to this medicine or that medicine, and what propensity does she have to disturbances of mood, just like we might be able to tell propensities for cancer.
Now, you and I, in our pre-interview, talked about the history of medicine, and actually medicines prescribed for psychoactive drugs. Do you want to talk about that?
Sure, I'd be happy to.
I'm amazed at what it used to be.
Psychiatry has a, shall we say, illustrious history.
Yes.
Or perhaps at times, as a psychiatrist, I can tell you maybe embarrassing. It would be nice to distance oneself from some of our history. But I could remind my non-psychiatric colleagues that we used leeches at one time as well. So certainly we've got to take things in context, that we did what we could when we thought that was the way to answer problems. And so certainly there are things that we did in the early 1900s that today are absolutely barbaric.
Right.
We don't do those things today. There are things that we have learned. There's things that we've changed. The first medications really that started out with any significance for us psychiatrically around the 50s, and that ended up really kind of coming out jointly of the tuberculosis difficulties in terms of studying the use of a medication to treat TB, which ended up actually having an interesting side effect of seeming to treat mood.
Really?
It's around the same time, but simultaneously, or maybe serendipitously, many would say, we discovered in some of the antihistamine research that antihistamine quality chemicals seem to also have an antidepressant effect. Wow. So out of that came some of the first class of medicines, which may or may not be completely of interest, but the MAOI inhibitors, which refer to monoamine oxidase, which refer back to dopamine, norepinephrine, and serotonin. And then the next would have been sort of the development of the tricyclic classes, which would be the classic Elavils and the Pamelors and the tenofranils type of medicine. The 80s marked a fairly dramatic change in the arrival of the SSRIs, which are the selective serotonin reuptake inhibitors. And that, of course, the Prozac marks that one. That was the first real blockbuster, kind of came on the market and I think changed a lot of people's ideas about, can depression now be talked about more openly? And I think it came along simultaneously with some real changes in attitude about, can we talk about depression? Can we look at depression? What is mood? And how does mood affect people? And Prozac certainly had controversy around it, as does any medication that is wildly successful, at least from a financial standpoint. Right. And also, I would add, clinically, I think we saw some enormously good results. When the research looks back, we may find that the SSRIs may or may not be any more really effective than maybe the tricyclics or the MAOIs. But I think there was a cultural change. There was a shift in our perception or our willingness to actually talk about depression and try treating depression. Around that same time, we saw physicians move also away from just thinking in terms of depression as a single entity, but looking instead at clusters of symptoms. Things, realizing that I could prescribe Prozac for a patient, and now they were less anxious. Interestingly, they used to not want to go to social situations, and suddenly they're talkative, or suddenly they feel less introverted. And around that time, a book was written by Peter Kramer, Listening to Prozac, which actually relayed a lot of his experiences as a psychiatrist, talking about watching some of his patients who seemed to actually change in terms of personality structure and the types of questions that raises philosophically in terms of what is the person, and do we alter that when we alter their biochemistry? Right. Do we change their structure in some way? And I think at some core level in humanity, that's very, very frightening, very threatening to think of altering our core in some way.
I don't think I'd want to change my personality
drastically. I think that's scary. I think that's very scary to people. But yet, if we could alleviate suffering in some ways, that's very noble. So there's always a balance point. And I think where we stand now in psychiatry is we look at risk and we look at benefit. And in essence, there really is nothing that's entirely free. There is no magic pill. Every medication has with it a downside, and every medication has a possible upside. And there are things that need to be weighed. And I think it's difficult oftentimes if a patient is suffering, they want to feel better. Right. The good news is that the majority of people who are treated for depression do improve. We're looking at 80 to 90% over time do report some dramatic improvement. Now, the downside of that is that it isn't immediate and it isn't always on the first medication. And I think that can be very frustrating to a person who's suffering, because when you're depressed, you would like to feel better.
I mean, I'm wondering, does it also include or require a change in your life or a change in your lifestyle, as opposed to all I have to do is just take a pill and feel better?
I'm very glad you raised that point, and I'd like to refer, I guess, back to my style of practice. And I think that it's my model. It's not necessarily everyone's model, but I think that it's all-encompassing. And I think that I need to start with a patient by talking about lifestyle. We need to talk about health, we need to talk about nutrition, we need to talk about diet and exercise, choices that you make in your life. What is the situation that you're in right now? Can you do things differently? I think that's the foundation. That's kind of the core. That's the setting or the backdrop, the context of where everything else takes place. Into that, then, we could put psychotherapy, which would be exploring those things, talking about those things, figuring out what the right choices are for you. Medication plays a role in that, and that would go back to where I found that as a therapist, there were times when I hit the wall, when you came up against a patient who had done all those things, and it wasn't enough. It wasn't enough to get to the next point, or they were so depressed they couldn't get out of bed to start the exercise program. They were so anxious it was too difficult to actually try to meet some new friends in the neighborhood, to do something that actually might have started sort of a synergy in a positive direction in terms of feedback to a person. at those points, I think medication is really important. I think it's helpful, and I think there would be many people who would be more than willing to say that medication can literally save your life in that sense, or give you your life back. Often I find people who have been depressed for many years don't even realize what was missing, because depression has become normal at that point for them. But
Right.
when they start to feel better, what you hear is thank you, I had no idea how bad I felt until I felt better. And I think it's very dramatic as a physician to hear that, and it's very rewarding too, I would say. I think that even though it's abstract in many ways, psychiatry can be very rewarding when you hear a patient who's really had their life altered that way.
I can imagine that for years someone could be undiagnosed and just think that life is bad on a general basis.
Right.
What do you say to that? What are the numbers, for instance, of undiagnosed depression?
Well, of course, when you get into ideas of what the unnumbered are, it's tough to do because it's hard to study people who don't identify themselves as depressed.
Right.
It's also tough to come up with a sample size, and the estimates vary wildly in terms of how many undiagnosed. What we have in terms of diagnosed is a pretty large number. It would be fair to assume that there's a great number of people who have, for whatever reason, not come to attention or have not put themselves in a position where perhaps they could be diagnosed.
Right.
My fear as a physician is that there are people who are suffering who don't need to be. There are people who, for whatever reason, think that there is too much stigma, or perhaps there is pride, or perhaps there is a difficulty in really acknowledging that maybe things aren't really where they should be. And it's tough because we're a culture that prides itself in being self-sufficient and being successful. And I think that is important, and I think that we value that enormously as a culture. At the same time, if you fall out of that and you're depressed, it can be very difficult to admit that I'm depressed. But at the same time, part of solving problems is being smart and recognizing that maybe what I need to do is look at this, talk to someone, find out, is there something here that holds me back? Is there something in terms of the depression that could be looked at?
Now, do you find that people are referring themselves, or do you find that people have their wives or friends saying, you need to go to a doctor?
And I'd say that that's probably as individual as the case. And I have a range of people. I have people in general who refer themselves, who say, I'm not happy. The extremes are easy.
Right.
The person who,
Someone tries to
it's
kill
always
themselves.
easy.
Well,
and
they need help.
Right. And if you take yourself down to that end of that continuum,
Yeah.
it's very easy to identify somebody who is classically depressed. They don't get out of bed, they're sleeping all the time, they don't eat, they feel like hurting themselves, or they've made an attempt. Those people are easy to find.
Right.
And unfortunately, at times, that stigma spreads backward down the continuum to those people who are functioning but yet are still impaired in many ways. And I think that's where there's enormous cost to our culture, to our society, to the individual in terms of not being able to maximize their potential, not being able to have satisfying relationships. It interferes with the ability to bond with your children, to take care of your business, to take care of your physical health. There's enormous correlation between physical health and depression as well.
I'm sure that's true. Now, what about reimbursement? I understand that there is no blood test, or there is no MRI or CAT scan that can say this person is mentally ill. And how much of a challenge is it for you to be reimbursed?
Well, it's tough. It's tough because it's science, and in science we like proof.
Right.
And proof means a group of people that you can study, and in the end you can prove statistically that a certain thing is there or not there. Psychiatry is tough for many of the reasons that we've said already, is that it's complex, and it crosses over biochemical into psychological and into the environment and into lifestyle and into personality. So it's tough. It's tough to say it's A, B, or C. It's really A, B, and C. It's all these things. So rightly so, for those people who foot the bill, third-party payers, they have a right to say, well, I need to know that I'm paying for something that works, that's
Right.
real. I'm not just paying for something that's imaginary. And I don't fault insurers for that. Certainly their right is to say, Dr. Allison, show me what you're really doing. Why is Peggy depressed? I mean, how do you know that? Prove to me she's depressed, and why should I pay for her to get treatment? And I think there's a challenge in that. I think part of it is needing to be able to articulate well what it is depression is, trying to define that. Ideally, we'll have a test someday that says, you know, your serotonin is 1.2 and your norepinephrine is 3.6 and your dopamine's down to 0.5, and you know, we need to get those levels adjusted. And at that point, in that point, perhaps some of the challenge and artistry of psychiatry may disappear.
I mean, do you think that one person would be diagnosed differently by 5 different psychiatrists?
Well, the classification system that the American Psychiatric Association has used, which is our DSM, diagnostic manual, in essence really tried to come up with a consensus guideline in terms of what most psychiatrists would say a certain presentation would be diagnosed as. So in essence, it's a statistical manual in the sense that it looks at a number of people who seem to have certain symptoms, and would the majority of psychiatrists call that a particular diagnosis. So in general, there is some consensus, but yet there is variability. And I think that's where we speak back to the individuality and complexity of the human, as well as, keep in mind, the physician is also a human, and we're also subjective. So what I may call depression, my colleague might not, and what I may call anxiety, my colleague might not. And a colleague may call something depression, and I may say, you know, I think this is about bad choices and about needing to do things differently in your life, and that feeling sad right now is appropriate.
I'm just envisioning more collegial debate amongst psychiatrists as opposed to medical doctors in other fields.
Absolutely, and I think our field is, as it should be, debating among itself all the time about the validity of our diagnostic criteria, about what do we define as illness, what is not illness. We have in many ways in psychiatry attempted to adopt very strongly a medical model. Part of it, I think, rises out of a concern that we need to be able to justify that there is indeed real suffering that could be alleviated. And the traditional way of doing that is to study a disease, to identify what causes the disease, what the natural course of the disease is, and what kind of treatments are available. So in psychiatry, we adopt that model with varying degrees of success, because oftentimes it really doesn't fit a disease. Oftentimes it's more complex than that. So I think psychiatry struggles to find its niche. Is it going to fall under medicine in a more traditional sense? Is it going to encompass a broader aspect of things that entail the self, the person, the spirit, the things that have often kind of gone toward what maybe medical psychiatrists would consider the fringe of psychiatry now? But I think there's a range, because we're talking about human behavior, human emotion, human thought, and the complexity is amazing.
It certainly is. Okay, we need to talk about further resources.
Okay.
We mentioned, you mentioned to me a few websites. The American Psychiatric Association is apa.org, or actually healthyminds.org.
Healthyminds.org.
The National Alliance on Mental Illness is NAMI.org. And there were 2 other ones, depression screening tests on the NYU School of Medicine, and the depression self-assessment on the Mayo Clinic website as well. And then one book that you are recommending, which is Feeling Good by David Burns.
Right. I'm a fan of that book. That's a style that I practice in therapy, which is a cognitive therapy approach. Those guidelines on the internet are helpful. I think they're a good starting point. I would caution viewers, of course, that it's difficult if you're in the middle of the forest to see the trees, or in the middle of the trees to see the forest. In a sense, it's tough to be the actor and the audience at the same time. So when you take any survey, For yourself, you're filling it out from yourself. Sometimes it's nice to have somebody else take a look at that. In fact, some of those surveys, if you have someone close to you fill it out for you, may be more accurate.
Aha. Okay. I'd like to thank you for coming today.
You're very welcome.
Very
Enjoyed
interesting information. Thanks for watching. We hope to see you next time on Focus on Health.